examination fundal height is 34 weeks are going to mark. So a patient presents to us at 34 weeks with bleeding PV. Yes, on examination, fundal height is 34 weeks. The uterus is tense. The fetal heart rate is 132. Blood pressure is 160 by 110 millimeters of mercury. And on PV examination, cervix is 2 centimeter dilated, 50% effaced, and vertex is at -3. Which of the following is the management for her? Yes, which of the following is the management for her? So what do you think are we talking about? Can you tell me what is your probable diagnosis? Anybody who can tell me what is the probable diagnosis? So I'm sure that one thing that comes to your mind is going to be abruption. Yes, so one thing that comes to your mind is abruption. But do you think that it could also be simply a case of preterm labor? Yes or no? Yes. Tell me, why would you have bleeding in a case of labor? Because that is going to be your doubt, right? Ma'am, the question says bleeding, right? So please understand, you can definitely come across bleeding even in normal labor, and that is what is described as show. Okay, so always one of the DDs for abruption is going to be labor. Also, some of you are going to ask me, ma'am, the question says tense uterus. So is the uterus, or can the uterus also be tense when there is labor? Yes. The difference is that it will show what? Intermittent relaxation. Yes, it will show intermittent relaxation. Now tell me, why would I think of labor more as compared to abruption? Because, do you see this? The fundal height is corresponding to the period of gestation. So most likely, this is not a case of abruption. It is simply a case of preterm labor. How do you know this is preterm labor? The cervix is dilated, it is effaced, and even the head has moved down into the pelvis, right? Is there any evidence of fetal distress? No, there is no evidence of fetal distress. Okay, now listen to me very carefully. Why should the answer be not steroids, tocolysis, and Magsalve, right? So please remember, she is a case of severe hypertension. Do you agree? Yes, she is a case of preeclampsia with severe features. Do you all agree? Okay. So when it is preeclampsia with severe features and the pregnancy is already at or beyond 34 weeks, do you want to give tocolysis? No. The management of preeclampsia with severe features at 34 weeks is delivery, right? So there is absolutely no role of tocolysis. Also, do we give Magsalve to all patients of severe preeclampsia? No, we don't. So as per the guidelines, we are not giving Magsalve to all patients of severe preeclampsia. Is that understandable? Steroids, do we have time? She is already in labor, right? And we really don't have time. So only about steroids, I could still think. But why is the entire answer wrong? Because there is absolutely no role of tocolysis. And in this patient, there is also no role of Magsalve as of now, right? Why is the answer not cesarean section? Why is the answer not cesarean? Because there is no indication to do a cesarean. Yes. What is the preferred route of delivery in preeclampsia? What is the preferred route of delivery? So the preferred route in preeclampsia is vaginal delivery. Also, even if you think it is abruption, let's say you cannot differentiate between the two. Even if we think this is abruption, what is the preferred route of delivery in abruption? Even in abruption, the answer is vaginal delivery. Why? Because for abruption, please remember, when do we do cesarean section? We do cesarean if the mother is unstable, right? Or there is evidence of fetal distress. Here, there is no evidence of fetal distress and the mother is not hemodynamically unstable. So doing a cesarean section is incorrect. Okay. Now tell me. No, bache, in IUD, the preferred mode will be vaginal delivery. Okay. If the baby is already dead, the preferred mode again will be vaginal delivery. Now we are left with two options. Okay, option B says give hypertensives and wait and watch, and option C says do ARM and give oxytocin. Do you want to give antihypertensive or not? Just tell me this. The answer is yes. She has severe hypertension. If you don't give her antihypertensives, she is going to go into stroke. Okay, she will develop stroke. Yes. Second, why do I think it is okay to wait and watch? Because she is already 34 weeks. I want to do a termination, but she is already in labor. Do you understand this? The patient is already in labor. Yes, so there is no need simultaneously to do ARM also and give oxytocin also. If you have attended classes, have we taught you that you don't do the two things together? Yes or no? Right? So ARM could be a possibility had the woman, not been in labor, or when we want to expedite the process of labor. Yes, but do we give ARM and oxytocin both together? No, we don't, right? There has to be at least a 30-minute gap between the two. You don't do both the things together. Yes, so now tell me, out of B and C, what is the better answer? Definitely, it is give antihypertensives and wait and watch. Even if she is abruption, this is what you can do. She's already in labor. Why do you want to do something as of now? There is no distress. Is there any need to expedite the process? No. Is the labor prolonged? No. Are there any complications of labor? No. So why do you want to do any intervention? Yes. So now do you understand why B is a better answer? Yes. So simply what you're going to do is give antihypertensives and wait and watch. Okay. Is that clear? Yes. Even अगर आप इसको abruption भी सोचोगे तो भी मुझे ये still B will be a better answer. This is what I want you to learn. You all know a lot of theory, but when it comes to application, that's where sometimes you falter, right? So please remember, when two options are incorrect, I talked about, are correct. I talked about this in the morning as well. Yes, that when two options are correct, what are you going to go with? The one that is more obviously correct. Yes, and that is definitely the one with antihypertensives here. Yes, is that clear to everybody? Preeclampsia and preterm labor can happen together. Okay, so anybody can go into preterm labor. Preterm labor is not a differential for preeclampsia. Labor is a differential for abruption. Is that understandable? Yes, everyone, are we good to go? Okay, perfect. Let's move on to the next question now.